It's Dr. Towfigh. Welcome to HerniaTalk Live. I'm your host, Dr. Shirin Towfigh. Many of you are joining me on Facebook on my Beverly Hills Hernia Center page. Thank you for joining me. We're here for your questions. So you can also follow me on Instagram at HerniaDoc. And if you want to see what I do on my academic side, where most doctors follow me, you can go on X, where I am also at HerniaDoc. And remember, if you love to listen to podcasts or if you want to catch up on episodes, I am on all of your podcast stations, Apple, Spotify, etc. And you can watch these videos on YouTube. We're up to 200 and something episodes. So really excited. We've had some really, really great downloads. And please do like and share, and that way more people can be able to see us. So I'm super excited because I've been asking this friend of mine to be on as a guest for many years. Her name is Dr. Talar Tejirian. She is a surgeon and founder of BootyMD. You can follow her at BootyMD on Instagram. And if you're into TikTok, I highly recommend that you also visit her on TikTok. She is going viral, and I'm super excited that she's a guest today because we're going to talk about everything booty. Hi, how are you?
Good. Well, thanks for having me on.
Thank you so much. So someone sent a text saying, what do you mean by booty and hernias? You want to explain why you use the word booty?
Well, for booty, I use that word instead of the technical term, which is anus.
Yeah, no one likes the word anus.
Yeah, medically speaking, anus is the word that's in the anatomy textbooks. I mean, that is the anatomical medical language that we use for the part of the body that passes stool. That's what it's called. It's called an anus. Now, people are uncomfortable with that word. And people are even more uncomfortable when you turn the word anus into an adjective, right? So
like anal,
right? Anal, technically speaking, is an adjective, right? Anal pain, anal itching,
but or anorectal. They use that sometimes.
Yeah, but in society, or I guess I don't know what the word is, it's become a verb, right? The adjective has become a verb.
Oh, like to be anal.
So the word has changed a little bit, and people are uncomfortable with that word. And really, people are uncomfortable about talking about any private parts,
True.
Per se. So there's no good word of making people comfortable, yet talking about that specific part of the body.
And I feel like that's been the impetus for BootyMD, because you're an educational forum, right?
Yes, it's BootyMD is really a nonprofit organization. And the reason why I came up with it was because it was almost 10 years ago. I met a local health reporter, the Channel 7 health reporter from over here in LA.
ABC.
And I told her, you need to do a story about people and their problems of, their anus. There's a lot of problems. No one talks about it. There's so much misinformation out there. I just see patients suffering every single day, patient after patient with poor information, suffering for years, scared to come out. You should do a story on it.
Which is why we're doing this podcast, but go ahead.
Yeah. So she came out. Well, she said, I need to record you. And I said, I don't want to be on TV. But she's like, you need to be in the, in the actual show. But you have to give 2 topics. So I said, okay, my 2 things that I do hernias and proctology, like booty problems, right? So she came out, she recorded both of them, and they aired the hernia one right away, but no one allowed her to air the one about the booty hole problems.
No way.
Yeah. So, and I watched what she did. She produced it very well. And then I said, what's the problem? She said, number one, like you can't say the word anus. I said, what do you want me to call it? Like, what do you want me to say? She's like, well, we'll say rectum. I said, but that's not the same thing.
Explain that. There's a difference between anus and rectum.
Yeah, so anus is the last part, the part that passes stool, and rectum is the higher part that holds the stool before you pass it, right? As like a simple definition. So you can't call the anus the rectum. They're different body parts.
And
So
they have different diseases.
yeah, different disease, different everything.
Mm.
So as a physician, a surgeon, a proctologist, whatever you want to call me, I'm
Yeah.
not going to use the wrong word when I'm
Right.
education. So at
Yeah.
that point, I realized we need a different word. People were comfortable with the term booty. So, so went with the term booty. And then I decided that I need to do this education however I can, because the information needs to be out there. And not only is the public not educated about booty hole problems, but
Yeah.
physicians aren't. Because think about how much time you spent in medical school or
Yeah.
anything learning about it. Little
Yeah.
to none, right? It's a very misunderstood part of the body. And because of that, people suffer.
So one of the questions posed was, I don't understand why you're talking about, because our topic is booties and hernias. You're a hernia surgeon and you're a booty specialist. So you understand how the two connect.
Yes, I mean, they can connect in a lot of ways because number one, they're sort of in the general vicinity, right? They're both, or a lot of hernias are closer down to the pelvis area, and the booty hole is down there. So when people have problems, oftentimes it could be vague and they could just feel problems down there and they're not sure what they're feeling. So that's
Down
one
there. Yeah. I hear the
down
word
there.
down there. Yeah.
The other point is, people are embarrassed to talk about it because, again, it's like in a sensitive part of the body, whether it's a hernia or booty hole problems. And there's a lot of other things that are connected, like constipation and hernias are connected.
A
uh,
lot.
Things like you can have pelvic floor spasm, that can be either pelvic pain or anorectal pain, different things like that.
Yeah, that's so true. There's already a question up here. It says, is there a difference between the rectum and the sigmoid rectum? Or I guess some people call it rectosigmoid.
So the sigmoid is the last part of the large intestine, and then it becomes the rectum, and then there's the rectosigmoid junction where they connect, and then it goes down into the anus. So
Yeah.
I have my Netter anatomy book. I should probably bust that out and bring it. It's holding up my computer right now. um,
Yeah, so I would say, like when they talk about cancers, right? There's a difference between sigmoid cancers and rectal cancers, and the treatment is different. So the sigmoid is just above the rectum, but sometimes they loop it all as like rectosigmoid because, like diverticulitis, you can have include the rectum and the sigmoid, but uh, that's distinctly different from the anus because anal cancers are different. You get anal fistulas, anal skin disorders, anal skin tags. Hemorrhoids are part of the anus. Is that correct?
Correct, yes.
Yeah.
They're a normal part of the hemorrhoidal tissue is normal anatomy. Now, when hemorrhoidal tissue acts up, that's when it becomes a problem.
Yeah.
But actually, everyone has hemorrhoidal tissue. That's part
Okay.
of our
So the things I'd love to learn from you, related to our patients' needs, which are mostly hernia related. One is um, talk about all the kind of anal or pelvic disorders that I don't treat, right? That maybe you treat that are related to pelvic pain or groin pain, etc. And then the second one is how is it that are there diseases where if you have a hernia, you're more likely to have an anal disorder and vice versa? And then what are some treatable problems that affect the anal disorder that can help reduce your risk of getting hernias?
Hmm.
And then the last thing I really want you to tell me or educate our patients is how to prevent, right? Like whether it's post-op, pre-op, all the anal disorders you can prevent as a hernia patient.
All right. So I don't know where to start. That's so much. Let's start with the most common anal problems that people have, and
Yeah.
then we can move on to the rest.
Great.
So most commonly when someone has a problem in their booty hole area, all they think about is I have hemorrhoids, right? But then we have to think, what is the problem? Do you have pain? Do you have bleeding? Do you have itching? Is something sticking out? These are all important things to think about when you have an issue about it. So if you have a problem down there, don't think automatically I have hemorrhoids. Say, what am I feeling right now? Because that's going to help figure out what problem you have. Now, one of the most common problems, actually, that's not talked about too often, that causes a lot of pain and discomfort for people and also bleeding, are anal fissures. And fissures, yeah. I talk about this a lot because it's mistaken for hemorrhoids very commonly. And it's because people have pain and bleeding, which often people think about as hemorrhoids. And they're very hard to see on exams sometimes, especially because when someone's having pain, they're clenching. And what a fissure is that it's a cut in the anal area, and it happens from passing a hard stool or anything that stretches the anus. And then you get like a cut in there. And it could hurt terribly. You can have bleeding because it's cutting. And you can also have spasm because now it's now you've hurt yourself, so that muscle is spasming. And then it spasms, you clench, and then that clenching then makes the cycle worse. So it's a big problem. They're often hard to see on exam unless you're looking very closely or you know what you're looking at. And sometimes when you have a fissure, you get a little piece of skin right next to it. And people often mistaken that as a hemorrhoid. And it's not, it's a little skin tag. We call it a sentinel tag next to the fissure. And that's just from that irritation and that cut being there.
I feel like it's so easy to just call everything hemorrhoids, and then most doctors don't even examine. They just ask questions like, oh, okay, so here's some hemorrhoidal cream, or you know.
Yeah,
Are you even supposed to use hemorrhoidal cream?
Don't get me started on that.
I know.
So one of the biggest problems that I see amongst medical practice is that physicians prescribe steroid creams for anal complaints.
Is that preparation H?
No, steroid creams are like hydrocortisone or different things like that, but they're prescription.
Okay.
And they have names like Procto, whatever, and there's no reason to prescribe a steroid cream for, let's say you have a fissure, right? A fissure is a cut. The last thing you want to do is put a steroid cream that impairs healing. Or if someone has itching, they'll give a steroid cream to it, and then it like thins out and irritates the area. So steroids should only be used for a very, very small select problems, and most people should not be getting it. So this is a big part of the education that I've done for physicians, which is don't prescribe steroids. But you're correct, the exam is not always easy, especially in a regular exam table, because in our proctology clinics, we have a special exam table, like you go to the gynecologist, they have special exam tables because you're looking at a midline structure. So you need to be able to see it in the proper way, especially when someone is in pain and they're clenching. So I think exams and people are uncomfortable showing their booty holes to even doctors. So
that's true.
To shy away from wanting to get examined anyway. So that's why there's a big misdiagnosis of problems. And that's also very common, being misdiagnosed. So that's very common. Anal fissures.
What's a preparation H then?
So
it's like witch hazel.
Let me talk about that now. Okay, so preparation H, in my opinion, is a placebo. Okay.
No way.
So the active ingredient in standard preparation H is phenylephrine. So phenylephrine is
cough syrup.
Yes. And if when you've been sick, have you taken phenylephrine and versus pseudoephedrine? Have you tried the two?
I don't even know what the difference is.
Okay. Well, I'm going to tell you it's very different. So here's pseudoephedrine is the real Sudafed that was available before. They started limiting pseudoephedrine because people were making methamphetamines with it, right? So right now, for you to get pseudoephedrine, you have to go and ask for it behind the counter and show your ID. You can get it, but it's limited. So what they put outside now is phenylephrine. It doesn't work when you have a stuffy nose. Let me be quite honest. I've tried both of them when I've been sick. So phenylephrine, even when you swallow it as a pill, does nothing. Now, in that cream, they're putting, I think, don't quote me on this, 0.1% or some tiny amount of phenylephrine. Yeah. And then that's the active ingredient. It doesn't do anything.
Is it just a cleansing cream then?
It's not even a cleansing cream. It's this yellow, horrible smelling thing that I just wouldn't like use ever.
It makes so much money.
Yes, I know. It's just something that I would never recommend to patients. And
what about the Tux pads?
I think the Tux pads are witch hazel.
Witch hazel, yeah.
Yeah, so that's just a cleansing pad. It's fine. Some people find it
it's astringent.
Yeah, I think some people like it, some people don't. I think it's, it's neither here or there as far as I'm concerned. But anyway, we're going sort of into the weeds.
Sorry. These are all questions I've been wanting to ask you for years.
Now the problem is I could talk about this for like 5 hours, so you got to stop me because I feel very passionate about this topic. Okay, so then we have hemorrhoids, right?
Okay.
So hemorrhoidal tissue that's part of our normal bodies, it can cause you problems in 2 categories. Number 1, you can have internal hemorrhoidal problems, which are bleeding. When your internal hemorrhoids bleed, it does not hurt. It's painless bleeding.
Okay.
So if you have pain and bleeding, don't think that you have hemorrhoids. Okay. So that's number 1. Number 2, you can have external hemorrhoid problems, which is like a blood clot, like a little marble that shows up at the outside of the booty hole. You feel that, that's called a thrombosed external hemorrhoid. It really hurts. You feel this like marble out there, and usually it's worse in the first 72 hours and then it goes away. So usually that does not have bleeding with it. So the reason why I'm saying this is that if you have pain and bleeding, you have to think more along the lines of, is this a fissure? And if you have painless bleeding, you think internal hemorrhoids, and you just have pain with a marble on the outside, you think thrombosed external hemorrhoid, right? So that's sort of the
I feel like that's so confusing. Most family doctors aren't going to be able to figure that out.
I mean, it's pretty simple, right? Like I can draw it out on a diagram. I've written I was the senior author on a paper about this called Anal Healthcare Basics.
Anal what?
Anal Healthcare Basics.
Oh.
Yeah, it's in PubMed.
Anyone just watch it, like read it?
Yeah, you just actually, if you type in Google Anal Healthcare Basics, it should pop up, hopefully, as the first thing.
Yeah.
And you could read it, and there's pictures and everything on there. It's meant for physicians, but it's, easy enough to read where everyone could read it. So these are the most common things that I would talk about. And any kind of spasm down there, anything that causes pain is going to make you spasm. And that spasm can also spread and be like pain in your pelvis in general. You might not just feel it down.
I feel like sometimes what happens is patients will have, let's say, hernia surgery, and then not by me, because I don't prescribe narcotics. I know it's not a friend of hernias, but it's common for doctors to give narcotics, actually any surgery, but let's say hernia surgery, and then afterwards, like, oh, I saw blood in my stool, or I have anal pain or something. So does that, if it were fine and then they just have this, is it good to assume, oh, they just probably have hemorrhoids, or that's hard to?
Well,
and then what do you do about it?
As we know, the opioids, or even if you don't have opioids post-operatively, sometimes the anesthesiologist gives it to you during the operation. You're also commonly dehydrated. because let's say you haven't been eating or drinking or different things like that. So
True.
it's very common to have constipation after surgery. Now, the problem is that often when you have that constipation, and if you're taking opioids like Vicodin or Norco, it's going to make you even more constipated. The problem is that you need to, the regular stuff that you try for constipation is not strong enough to combat this opioid, post-surgical constipation that you have.
Like Colace, that never works.
Yeah. Colace, otherwise known as Docusate, is one of the most commonly prescribed medications for constipation.
Yeah,
and there is zero evidence that it works. Zero evidence. I'm going to put this out in your podcast too. If anyone could produce one article, quality article that shows that Colace works, I will send you a present because it does not exist. Colace does not work. And then they give you Colace and people are taking this medication and they're like, I'm still constipated. I don't know what to do. And then the problem becomes, let's say you don't poop for like 2-3 days, right? After surgery.
Yeah.
What happens at the first part of the poop, that first part is like a rock. That rock has to come out so the rest of the stuff comes out, right?
Yeah.
That rock coming out can tear your anus.
Oh.
And then you're going to get a fissure on top of the pain that you have from your surgery. And then now you have anal pain, bleeding, likely from a fissure because you had to pass that rock that's like that stool. So laxatives, right? So there's stool softeners, which is what we talked about, the Colace.
Not helpful.
Not helpful. But laxatives, those could be helpful after surgery.
So I tell my patients, especially those I really don't like, either have a tendency or they had a big operation, I give them milk of magnesia, Miralax, and sometimes mineral oil, all the M's. Is that good or bad?
I think that's a pretty good combination that you give them. Like, do you tell them like to take it in a specific order or how?
I usually start with milk of magnesia 2 or 3 times a day because most people don't mind the taste of it and it's mild. If they need more, I give them Miralax once a day. And then most people don't like mineral oil, so that's my third choice. But some people prefer mineral oil, so just take like a tablespoon with a meal.
Yeah, I think that's pretty good because milk of magnesia is a good laxative. And if they take it early on, it's going to prevent that little rock forming, that little rock hard stool forming at the end. So that's going to be really great. It also acts like it acts a little bit as a stimulant. So milk of magnesium in many forms is good. Miralax, in my mind, is almost like a man-made fiber. That's how I think of it. So I don't think it's strong enough to combat post-operative constipation or constipation from those medications. It doesn't hurt, but I think by itself it's just not enough. And mineral oil is like a lubricant. So I think it's fine for temporary basis. The problem with people that use it all the time, it can coat your lining and prevent you from absorbing like the minerals in your food or the nutrients in your food. Sorry, I should say.
What about Senna? Some people love Senna, but other people feel really bloated and crampy with it.
Senna and Dulcolax are both stimulant laxatives. I think they are good to fight the post-operative constipation. And that's because the medication you get makes your colon lazy, right? The opioids, they like stop your colon from working. And the Senna and the Dulcolax, they stimulate your colon. So I think those are, but yes, it can cause cramping because it's stimulating it, right?
But there's Senna tea as well, right?
Yes, it's the same thing. It's the same thing. The problem is you don't know how much you're getting in the tea, right? Like you don't know how much. And any of these laxatives, you don't want to use that long term. Because
but I know you're a big fan of foods that are naturally high in fiber. So I'll just give you my little story that other people don't know. When I had I think it was the first time I needed surgery, it was for my neck. And Dr. Tejirian here, she got me a goodies bag, and it had everything you need to prevent constipation. Like it included like fig Newtons and like I don't know, did you have like dates or kiwi or something? And then um she had butt cream. She had definitely fiber and some fiber crackers,
I'm
but
sure that said in there, didn't it?
lidocaine cream, I think, for the butt. Like I don't know what you thought I was gonna end up doing, but it was like the cutest, most thoughtful goodie bag for my post-operative constipation prevention.
I have to, I hate it when patients suffer unnecessarily. So
Yeah.
the times that I think about it is post-operative patients suffer, and you know who else suffers? Women that just gave birth.
Oh
Like
yeah.
there's this like level of suffering that is unnecessary because we have stuff out there that helps you. Why
Yeah.
are we tortured? Like just use it for that time being, get through that tough period and
Yeah.
stop suffering with it. You know what I'm saying? Not only that, but like even women during their menstrual cycle, there's times where they're constipated, and it's very common during that time for them, like every month to get a fissure. Why are
Oh,
we
wow.
suffering? Like, let's use what we have at our disposal. The other thing I want to talk about that people are scared of are enemas. Can we talk about enemas?
Okay, so from a layperson, I know of two types of enemas. There's a Fleets enema that you can buy from the store, and then there's what we call a tap water enema. And when we were residents, we were told to order soap suds enemas. And there were some people that were used to always giving themselves enemas, which I thought was not normal. Um, but it, I'm taught instead of pushing from above below, you're pushing from, you're cleaning out from below,
Yeah.
right?
So the best time that an enema works is when you have that rock that I talked about, right?
Okay.
You haven't been to the bathroom. You just had hernia surgery.
Yeah.
You haven't pooped in 3 days. You have this little rock at the end. No matter
Okay.
what you put up top, it's not going to
Yeah.
break up the rock, right? Sitting right here
Wow.
at the anus, right?
Yeah.
So you got to go from the bottom to break this up. And the most common one is the Fleets enema that you're talking about.
It's pre-made. It's like easy.
The,
You just buy
the
it.
pre-made. I wish I had a sample so I could show people how to use it. I have a sample in my closet, but I don't want to go get it. So basically, that's like, it's pre-made, and it's basically pushes liquid up there just to break up that rock. That's pretty much what it's doing. It has a little bit of a stimulant effect when it's that Fleets enema, but they
Uh-huh.
also make mineral oil enemas. They actually sell that too. It's
That seems messy.
configuration, it doesn't work as well, because the higher the volume you put in there, the better it's going to break things up, and the mineral oil is like not as high volume. But honestly, they even make uh, enema containers, and you could just fill warm water and it's fine.
Okay.
Now, the thing that I would tell patients is that when you read the instructions on the Fleets enema, it looks scary. Like I look at it, I was like, what are these positions that people have to be in to use this enema?
Oh.
It is crazy. Like they're like, you have to lay down with your leg. It's like acrobatics to get it in. You don't have to do that. Like, why? Why are the instructions like this? It's like you have to just lubricate it a little more and just squat down a little bit. And for women, I tell them it's like using a tampon, but a little further back. You don't have to get into a weird position. No woman like lays down on their side, whatever, to get a tampon, and you don't need to do
Right. That's
the
true.
enema.
Maybe the lawyers got involved.
Yeah, I have to show you one day. I wish I brought it from my cabinet so I could show you now. But anyways, it's not necessary. It's not scary. It doesn't hurt. And people are afraid of putting things up there, but it's like this. It's like really thin. Like
Yeah,
the
soft tip. Yeah.
yeah, once you relax, it's just fine. And it really helps prevent that first part of a hard stool, and then it just prevents so many problems later on.
So if someone's preparing for surgery, any surgery, honestly, we're talking about hernia surgery, should they just go buy a fleece enema or wait or
I think if they're normally not constipated, it's
yeah,
probably not
okay.
necessary, because especially because we don't really prevent people from eating. We don't do the old school, like only do liquids for 72 hours. We're not doing those things. So they could be eating their fiber, having their water beforehand. I think it's only later, and not everyone's body is going to get constipated. That's
Sure.
the thing. Everyone's body reacts differently. It is so individual. So I don't think I can make a blanket statement about anything. You have to see how your body reacts.
And I know you're a big fan of the natural way of preventing constipation, whether it's around the time of surgery or in your daily life, because as we know, constipation is the #1 cause of hernias that is treatable, especially in the United States. But what are some tips about like dietary changes or natural ways to prevent constipation?
If I think a lot of people have heard that we recommend, or the recommendation is 25 to 35 grams of fiber a day. When you look at what that is, it's not all that much if you're eating whole foods, natural foods, and the more the food looks like it came from nature, the more
Mhm.
fiber it's going to have, right? So
Okay.
if an apple looks like an apple, it's going to have a good amount of fiber. If
Okay.
an apple turns into apple juice, it's going to have little to no fiber in it.
Uh,
So the food has to look like it came from nature for you to maximize the fiber that you're going to get from it. So if you're eating a lot of vegetables, a lot of fruits, some grains, things like that, and drinking a good amount of water, typically you will get a good amount of fiber in it. Now, the problem is a lot of people don't, because it's the culture that we live in, the society that we live in. We eat a lot of packaged foods
mhm.
that takes the fiber out of foods, or they put in these like weird kind of aftermarket fibers, I call them, like even in the
Yeah.
hospital, I look on patients' trays sometimes what they're having, and someone had apple juice that was they had supplemented with corn fiber in the apple juice. Like, why? Why are we making this product? Like you're extracting fiber from corn and then putting it in apple juice, whereas if you eat an apple,
Apple would be better. Yeah.
it's giving you enough.
Yeah.
And there's fiber supplements that are sold that
Yeah.
are not necessarily great. And
Mm.
some of them are really great, some of them aren't. For example, fiber pills, I think, are a super waste of money.
Really?
Yeah. Fiber pills are normally, there's something called psyllium husk fiber.
Yeah.
You've heard of psyllium husk, like it's
Yeah.
stuff in Metamucil,
Mm-hmm.
except Metamucil mixes it with orange chemicals. So if you're going to take psyllium husk fiber, just get the pure natural psyllium husk. You don't need the orange chemicals with it.
Yeah.
They take that and then they put it into pills,
Mm-hmm.
and they put half a gram of fiber in a pill. Now, if you think
Half a
half a
gram.
gram, so it says 500 milligrams if you look on the label.
Oh, wow. You're right.
Yeah. So if an apple has 5 grams of fiber, you have to swallow 10 of those fiber pills to equal the amount of fiber in like an apple.
That's crazy.
Yeah.
I
So
didn't know that. Oh my God.
yeah,
Wow.
it's sort of when you start to read labels and look deeply into it, you're like, what are we doing? Because if we just eat good, natural foods, we're going to get fiber in a lot of ways. And there are good ways of supplementing fiber too, like the psyllium husk fiber, or there's other kind of like powders that are good natural fibers you can add to your food. That's fine too.
Okay.
Chia seeds.
Yeah, chia seeds I heard are really high in fiber. And those are the ones you can leave overnight and they become really tasty, right?
Yes, it can give you a little gas in the beginning. So if you're going to ramp up on your fiber, you want to start slowly and then go up on it, because if you go from 0 to like 50 grams of fiber, you're
Yeah.
going to be really bloated and you're
And
going to be
then
really happy.
and I heard kiwis have a lot of fiber. Is it blueberries?
Blueberries, raspberries have a lot of fiber.
Raspberries. Yeah, I
Yeah.
didn't think berries would have fiber, but I guess berries have fiber.
Yeah.
Um,
Plus, they have so many other amazing nutrients
yeah,
too. Green leafy vegetables, a great way of getting fiber.
yeah. All the salads, I assume.
Yeah. And then the more you mix in, the better combination that you're getting, the better it is for you. You know,
Okay.
anything that takes a long time to chew, basically.
Okay. Here's a question. What is the correct way to insert a rectal suppository? And are there any dangers to using such as anal erosion?
So suppositories, I guess the question is, what is it being used for? If it's being used for constipation, the question is using that versus an enema. So as far as I'm concerned, if you need something from below to break up the hard rock stool, an enema is going to work better, hands down. You can try this.
There's a Dulcolax suppository
Yeah.
and there's a glycerin suppository, right?
Yeah. You can try them, but
Mm-hmm.
for it to break up that hard stool, an enema is going to work better, because the suppository is just sitting in the anal canal, right? So it's just sitting like further,
Doesn't go up higher.
unless you push it up, which is hard for people to do. But again, a correct way is to put lubrication on it, anything that could make it slippery,
Yeah.
and just relax. And it shouldn't hurt you. That's the main thing. Don't do anything that hurts. If it hurts, you need to stop. And it could be hurting because you're clenching.
Mm-hmm.
That's often very common. The clenching could make it hurt. Or it could be hurting because something's wrong down there and you need to see a doctor and get an exam.
Got it. So I learned this suppository for pelvic floor spasm that's compounded, and it includes, let me get this right, baclofen, ketamine, and Valium, I believe, these three ingredients, and it works really well for pelvic floor spasm. But there's
Yes.
no risk of anal erosion, right?
No, no.
Yeah.
I've never heard of that being a
Yeah, I never
problem.
heard of
I
it.
mean, it's because whatever you put in there is going to dissolve. Erosion would happen if something is in there for a long
Yeah.
time and just like causing that like pressure
Yeah.
to happen.
Here's another question. Can you describe the quality and location of the pain associated with pelvic floor spasm? Is it aching, burning, sharp stabbing, or burning? Yeah.
It could be any of those things, interestingly,
Mm-hmm.
because pelvic floor spasm goes into multiple categories, right? So there's the stuff I deal with more, and then there's the stuff you deal with more. So if the pelvic floor spasm is coming from something like the muscles of the pelvic floor around the rectal area, the levator ani syndrome, that feels like a dull kind of aching pain that can be chronic and last a long time. Then there's proctalgia that can be like sharp, just like lasting a few seconds, those kind of pain. And then there's a spasm associated with the anal fissures. And that usually is worse, like while you're having a bowel movement or while you're clenching. Or for some people, it's like when you're stressed. Some people get migraines, right? Some people
Yeah.
get abdominal pain. Some
Oh,
people clench their pelvic floor or their anal area and they get pelvic floor spasm, or they get fissures. So I tell a lot of my patients, it's like maybe your cousin gets migraines. This is what you have when you're stressed out. So we got to learn how to
I
relax.
did not know that, because they're definitely a class of people that are just prone to pelvic floor spasm, and it's just so hard to treat them. Some of them get Botox in the pelvic floor. Some people, they get complications related to the suppository and all that. I would say related to what I do. I have learned that hernias can cause pelvic floor spasm. You fix the hernia and the pelvic floor spasm goes away. And I learned that because I would have patients that would have hernias and at the same time had lots of pelvic floor physical therapy for pelvic floor spasms. And as a side effect of the pelvic floor spasm, they would have urinary frequency because the urethra goes through that pelvic floor muscle that's spasming, or they'll have pudendal neuralgia because the pudendal nerves go through the pelvic floor muscle that's spasming. But then you fix or they get rectal pain, anal pain?
Well, it could be both.
Could be
They
both.
could
Okay.
have it like
I get all nervous around you.
depending on where they're getting the spasm.
Yeah, anorectal pain. And then you fix the hernia, and all those downstream side effects eventually go away because the pelvic floor spasm goes away. So they don't need to see the urologist anymore. They don't need to see the proctologist anymore. They don't see the gynecologist or neurologist because the hernia repair fixed everything. And I started seeing this pattern. So we're trying to get that kind of out there to teach people that hernias can cause pelvic floor spasm.
The problem is that it's such a complex area. The pelvis is such a complex area, and it's complex for everyone.
Yeah.
And when you don't see an obvious cause, like you look on exam, you don't see anything. You get imaging, you don't see anything. And the problem is that a lot of radiologists are not as focused on these nuances that you understand when you're looking at hernias, right?
Yeah.
So, and as surgeons, we're not trained in looking at MRIs. You are obviously knowledgeable about that, but most are not. They're difficult exams to look at. So it becomes frustrating for the surgeon. It becomes frustrating for the patient because we can't find it. That's why it's amazing to have people that have this specialty knowledge like you do, right?
Yeah, but it's because you just see the same thing over and over again. I didn't learn this in medical school,
Yeah.
I have a great question for you. It says, I have done a colonoscopy and hemorrhoids were found. What shall I do and what kind of treatments are available?
All right. So I love this question. Thank you for asking it. Okay. I'm getting ready to answer what I think about
That's
this.
pretty common actually, that you do colonoscopy, like, oh yeah, findings hemorrhoids.
Everyone. Okay. Let me tell you why. What do you do right before you have a colonoscopy?
Bowel prep.
Bowel prep, right? You're drinking that
Pooping.
stuff. You're pooping 500 times. You're sitting on the toilet. That's what makes the hemorrhoidal tissue swell up. From sitting on the toilet, the gravity, and when you're spending the entire day before a colonoscopy on the toilet, your hemorrhoidal tissue is going to be swollen. That's,
it's veins. It's just basically, it's like varicose veins of the.
It's
veins.
Tissue, and it's tissue and it's veins, and it's going to swell when you sit in any position where your anus is hanging. So if you sit on a donut, it's going to swell. Don't sit on donuts.
Don't sit on donuts.
Don't sit on donuts, please. But you're prepping the day before. You're sitting on the toilet almost the entire day. Of course, your hemorrhoidal tissue is going to swell up. So it's a very common finding on colonoscopy because you've been bowel prepping the day before. To me, as a surgeon, that finding means nothing. Okay. The question is, are you having any symptoms, right? Are you having any kind of painless bleeding? Are you having those thrombosed external hemorrhoids? Do you have skin tags? Like, what is the issue? So that's one thing. The second thing I want to tell everyone is that a colonoscopy never takes the place of a proper examination of your anus. You need, if you're having problems of the anus, the colonoscopy is not enough. When they do colonoscopy, they are not looking in depth at it. They're looking at the rest of your colon. So if you have problems of the anus, if you have problems of the booty hole, you got to get an examination of the booty hole.
Well, oftentimes they stick not to be gross about this, but they stick the tip of the scope through the anus part, And then they start so they stick that in, then they start looking through the whole colon, including the rectum. But I mean, I'm sure there are great gastroenterologists that also examine the anus, but a colonoscopy in and of itself is not meant to do a good anal exam. It's the rectum and above, which is why the
Exactly.
terms are important.
Exactly. And plus they often just look at the anus from the outside, but they're in this dark room, you're on your side. It's
Yeah,
not an
dark room. That's
ideal
true.
position at all.
Dark room.
And I have to be honest, like I don't want to scare people, but the number of misdiagnosis of cancer, anal cancer for hemorrhoids is astounding.
Yeah.
And it's because people are not getting exams. It's because just assume problems are hemorrhoids. So the main thing is don't assume you have hemorrhoids, get a good exam. Your doctor needs to have looked at many booty holes to be able to give a good exam. That's the main thing that I could say about it, because it's not something that is practiced commonly unless you're doing it all the time.
Yeah. We have another question, but it's a hernia question. It says one surgeon said that the mesh complication will occur in the groin on average at 4 years. Is this correct? That makes no sense.
I can even answer that.
That is not correct. So I would say the hernia recurrences can occur, around maybe average 4 years. But actual mesh complication occurs shortly after you place the mesh. Because if it's folded, it happens early. It doesn't happen years later. If it's infected, very uncommon, but that's either an early problem. That happens early as well. And then other things are not mesh complications like nerve injuries and I guess inflammation from the mesh. That also occurs early. Even the mesh implant illness, which is super rare, also occurs early. So if you don't have a complication from your hernia in the first, I would say several months to a year, it's not a mesh related complication. It's a hernia recurrence. The stuff that happens later is usually a recurrence. Any thoughts or comments about that?
I was just thinking, and tell me if I'm correct. When for hernia repair, a lot of the problems are blamed on the mesh, right?
Yes, all the
That's
time.
the same as for the anus. A lot of the problems are blamed on hemorrhoids.
There you go.
And I think we could both say that neither of those statements are true,
That's
right?
true. That's true.
It's very nuanced and you need to get to the bottom of it to be able to treat patients to be able to treat patients properly and to give them the care that they need.
Okay, here's another question. Hi, doctors. Are you able to speak about the butt/hip pain from hernia surgery, piriformis/quadratus femoris area? Booty is fine. Sorry if I'm off topic. LOL. So in other words, pain, butt and hip pain from hernia surgery. I would say hernias can cause pain radiating around to the lower back, but it doesn't technically cause hip pain or butt pain. That's usually a hip disorder problem. Or you
Or,
have
I
like a
mean,
spine
are we
issue.
talking about groin hernia?
Yeah, if you have groin hernia, you can have pain radiating to your lower back from a groin hernia. But it's technically not the buttock. The buttock is usually a hip disorder that causes actual buttock pain, or it's like a spine problem.
Could it be a situation where the hernia repair has nothing to do with I think the question
Yeah.
was after hernia repair, right?
Yeah, I think you're right. I think sometimes people have a hernia, so it's like obviously like the hemorrhoid, right? But that's not the reason for their pain. They have a hip disorder or a spine disorder that's causing their butt or hip pain. Uh, and then they see a doctor and says, "Oh, it's your hernia because I can see this big bulge in my face." And then they get distracted to getting hernia surgery, and it's not the hernia after all. I hope I answered that correctly. I don't know if that was the intention of the question. Okay, so here's another. So the same person asked about the 4 years of mesh complication. Said mesh will degrade over time after being implanted in the body. Is that correct? Not really. This is why I worry about hernia mesh. Is there a best hernia mesh available? So there's no clinically relevant degradation of mesh in the body. We did have surgeons that explanted meshes for whatever reason and then looked at that mesh. Bruce Ramshaw being a classic surgeon who did that, one of our previous guests, and then looked at that mesh under the microscope. And if you look at it under the microscope, you can see some meshes in some patients. So not all patients and not all meshes had like the fiber wasn't perfect. It like had like a little bit of like flaring, you know. We don't really call that mesh degradation. It's still the same mesh, just microscopically it looks different. And what they notice is that same product in a different patient will look totally normal. So it's unclear how each patient can, it's unpredictable how each patient can react to a mesh. But no, so degradation over time of mesh is not any issue we ever talk about with hernia surgery. It's not something a patient should worry themselves about, right?
Unless the surgeon is using one of those meshes that absorbs, are they
It's
like,
supposed to degrade. Yeah.
yeah, I guess unless it's specifically about that.
And then the question is there a best hernia mesh available?
Oh. I'm gonna defer to you on that one, but I would imagine that the
Not
answer
yet.
is,
Not yet. Everything has
uh,
pros and cons.
yeah, individual, you have to pick based on the individual, right?
Yeah, I mean, you can prefer certain meshes over others for that kind of tailored care, right? So some larger hernias need heavier weight meshes, some really small hernias may not need any meshes. So there's a wide variety of options, but do we have the perfect hernia mesh? Right now, I would say no. We can still improve everything about our mesh implants.
Yeah.
Okay, going back to the patient that talked about the hip and butt pain, um, they're wondering if you can have potential nerve entrapment in the inguinal area from the mesh that then causes butt or hip pain. I would still say no to that. Because the only nerves you can cause entrapment if it's an open repair is the ilioinguinal iliohypogastric nerve, maybe the genitofemoral nerve. None of those cause hip or butt pain. You can have pain radiating to your lower back, but not lower, because it's a L1, L2. So it's upper lumbar. And then robotically, you can have lateral femoral cutaneous nerve or genitofemoral nerve injured. Laparoscopically, same situation. None of those give buttock or hip pain. So I'm going to say if you have buttock or hip pain, you probably have a hip disorder and maybe a spinal problem. It's not your mesh or your nerve or it's not related to that. That's what I'm going to say.
Yeah, I think again, it highlights how complex the whole pelvic area is. The anatomy, how complex it is, diagnosing problems can be complex, and different things like that. That's why I think it's great when doctors are just focused on that area all the time, because
Yeah,
like someone like you who sees it all the time,
yeah,
you're better able to differentiate, because again, it's a very complicated and anatomically complicated part of the body.
agreed. Follow-up question on the patient who had the colonoscopy and had the hemorrhoids. I have done a colonoscopy and diverticula were also found. What shall I do and what kind of treatments are available?
So diverticuli are outpouchings in portions of the colon. And there's several theories of why they exist. And one of the ones that we believe is because of a lack of fiber in the diet that's causing increasing diverticula for people as we go away from eating high fiber foods. So when someone has diverticular disease, the question that we have to ask is, again, like, are they symptomatic or not, right? So there's something called diverticulitis, which is inflammation of these of a diverticulum, or these outpouchings. And when that happens, usually people are in a lot of pain. They can have fevers, and they get seen in the emergency room, typically get a CT scan, and you see inflammation of the colon. So that has its own treatment as far as what you do. If you find diverticula incidentally in a colonoscopy, meaning the person has never had problems in their life and you just happen to see them, again, the endoscopist who did the colonoscopy has to say, like, is it just scattered? Is it a lot of them? Is it a little? But at the end of the day, we believe that fiber, good nutrition, fiber, adequate water is one of the best helpful things to prevent diverticuli from forming in the first place, which is also something really important for the colon, right?
Yeah.
And prevent diverticulitis from happening. And there were recommendations, and you still hear them a lot, of like don't eat nuts and don't eat seeds. But the last time I checked, those were debunked, because the concern is, like, you don't chew
That's
that
true.
and
Yeah.
they get stuck in the little outpouchings, and they can
Yeah,
cause
they said no popcorn, no seeds, no I don't know, things with like little strings, was it beans or
it
certain
was, it was
spinach
like,
or lettuces or
yeah,
something?
like nuts and different
Nuts and
like that can
popcorn.
get stuck. So that's sort of
Debunked.
a common thing that you hear. But the last time I checked, I think that theory had been debunked. But I would have to look that up to make sure that there's no like current information about that. But for anything for colon, rectal, anal health, the best thing you could do is healthy diet, lots of high fiber foods, adequate hydration, not sitting more than 1 or 2 minutes on the toilet, raising your knees on the toilet, like using a stool or something to raise your knees. You can even lean forward to get a good position.
Oh, so is that good for anal health?
Yes,
Okay.
because that is putting your body in a natural position to poop normally. So, you should, if you have your phone, almost everyone has their phone now when they're on the toilet, right?
Yeah.
Put a timer. Put a timer when you sit. Don't sit more than 2 minutes, right? I've heard some people say 5 minutes, still a little too long. If you haven't finished, at least get up and come back, or at least lean forward, like take that pressure off that anal area. Do some things where you're not just sitting there with that pressure on the anus. And then when you're
What if
done,
you don't? What if you answer all your emails while you're sitting in the bathroom?
listen,
Or you gotta finish your New York Times Wordle.
there are some people that are very lucky and they never have problems, right? But the chances that you will have hemorrhoidal problems from sitting on the toilet increases substantially the longer time you spend on the
And
toilet.
can you explain why that's bad? I mean, so what if you have hemorrhoids?
Because you're basically sitting and your anus is hanging down and gravity is pulling it, right? And that's making all the blood and all the pressure rush to those hemorrhoidal tissue with the veins, and then you have the swelling. And that's commonly why people will either get the internal hemorrhoids that are big and bleed, or when the blood rushes to the external hemorrhoid, they'll get a blood clot, which is the
Very painful.
external hemorrhoid. And that's because of that pressure and sitting down with nothing on the bottom, but gravity's pulling you down.
And that's very painful. And our guest last week, which was Dr. Zagian, she made it very clear, or 2 weeks ago, she made it very clear that one of the most painful operations you never, ever, ever want to have is hemorrhoid surgery.
Yeah, exactly. So not sitting on the toilet for a long time, is prevention number one.
Okay, I'm going to ask you our final question because we're out of time. Now that you sat for your 2 minutes, can you wipe your ass with your booty? Can you wipe your booty with those cleansing wipes they use for the baby wipes? Is that the best way to clean?
Yeah,
The
no,
baby wipes,
honestly, I wish I had
unscented.
I wish I had like a
The
big
honest
bonfire.
brand, au natural, unscented baby wipes.
I would throw those in the bonfire with the preparation H and the steroids, whatever. No, that is not the best way. It can cause a lot of skin problems, actually. And itching of the booty hole is a very common problem. And it's often because of chemicals that are in the wipes, or even wiping too hard, cleaning too much with the toilet.
Mhm.
So cleaning with water is the best way to do it. And then you could pat it dry with
Like in the old country, like in the old country.
yes, when they did it right, when they pooped in the hole in the ground, that was the right way of doing it. You can't scroll on your phone for 3 hours while you're squatting in the woods. You know what I'm saying? That's the right way.
Yeah.
So cleaning with water, gently patting it dry, it is sort of the best way of doing it. You can even get handheld little water dispensers. You don't need to get a fancy bidet toilet, although those are very nice. Way better to spend your money on that than on, whatever, shoes, purses, or whatever.
So I know Dr. Tejirian personally. She has custom made bidets and custom made stools in every bathroom in her house.
Yes,
Which
and you will never find any kind of expensive clothing or purses or anything on me, because I would rather spend whatever money on a nice toilet that's going to keep my booty hole healthy. But so I have all this information on our website, so bootymd.org. I
yes.
have some articles on there on how to clean your booty, on how to prevent postoperative constipation. On, one of the articles is named "Do I Have Hemorrhoids?", which goes through like the different things that you can have
Oh,
in
that's a
there.
good one. Yeah.
I have one about how thong underwear is not good.
Thongs are bad for you.
Yeah, only wear it if you have to. And I'm always open to suggestions on what other topics people are interested in, so we could write about that, but that information is there and available. And soon we'll have some more downloadable guides and things like that we're working on right now to put on the website.
So that's on your website, bootymd.org. You are a nonprofit. And for the love of God, if you want to have fun with booty stuff, do follow Dr. Tejirian on TikTok. She is
I have to tell
hilarious.
you, I was looking, I was like, what is my handle on TikTok? I should know
It's
this.
at Dr. T Booty MD. Dr.
I think
T,
it's just,
like
no, it's just at
Booty
BootyMD.
MD.
It's just at BootyMD.
Is it
The
at Booty
Dr.
MD?
T is the X one that we're not really like focused on right now. So it's
Oh,
at
okay.
BootyMD.
Okay, at Booty MD. Very good.
At
All right.
BootyMD. Yeah, we're gonna go in a different direction for that too, because I'm not really a mean person. So
No, you're a very nice person. Okay. We had
we're
so much fun. That hour went by so quickly. I love it. Thank you so much. Well, you learned it here. No thong, 2 minutes on the bathroom. Don't spend your money on preparation H, and do prevent constipation because there's so many great health benefits, including no hernias. Um, that's it for us at Hernia Talk Live. Thanks, everyone. I will see you again next week. Don't forget, like and follow me on YouTube and any of my podcast channels to listen to everything, including this podcast, this episode, all prior episodes at Hernia Doc. And I'll see you on Instagram where we'll have fun. Thank you.
Thank you, Dr. Towfigh. You're the best.
Bye. Thank you.